Thank you very much. It's lovely to see so many familiar faces here, and I can see people on the call who have done the course or who are actually currently on the course. Can everybody see that okay? Yeah.
Yes.
Thank you very much. So I'm Audrey Rolson. So I'm a professor of social work and palliative care and the program director for the MSc and the Postgraduate Diploma in Palliative Care for social workers at Queen's. So for anybody who's not familiar with the program, it's a 2-year part-time program that's delivered online. So we do 3 modules per year, and it's aimed really at social workers who are in the statutory and voluntary sector who are really keen to develop their skills, knowledge, and values regarding generalist or specialist palliative care. And you can see some of the teams that people have come from who are on the course or who have completed the course. So our first cohort, who we've got some of the people here today, they graduated there in December. And the module that we're going to be presenting from today is a research skills module where each of the students were asked to design and conduct a small research project within their own organisations. That's why we called it a backyard research project. And for some people, it was a service evaluation. Some people did a retrospective audit. Others did a survey. And then we have a few who did empirical research studies. So we've got 4 of our graduates presenting today. So the first one I would like to introduce then is Aislinn. So Aislinn Delaney is in the Northern Ireland Hospice, and she is going to present on her empirical study then where she explored stress and burnout in frontline hospice staff.
Just let me share my screen. Can you all see that okay? Yeah, thanks, Marvin. I can see you nodding there. There we go.
Sorry, just put it. That's it. Yes, that's it. No.
My computer has decided it is stopping for the Easter holidays, so it's it's running a bit go slow today. So hello everybody. My name is Aislinn Delaney. I'm the social work lead in the Northern Ireland Hospice. So I manage the social workers in the inpatient unit and our bereavement service as well. As part of my role, I'm also in the clinical lead for the organisation, clinical lead group for the organisation that makes, I suppose, organisational level decisions around the work that we do. So the backyard project that I undertook was to look at the cost of caring. So it's called the cost of caring, an audit of frontline palliative care staff's work-related stress. So the aims of this project were to identify burnout patterns in relation to the length of service, to establish what support staff use and find supportive, on what, sorry, that's cut off a bit, and what more the organisation to do to support staff in their work. And the objectives were to ascertain how stressed the frontline clinical staff in the hospice or IPU are, and what are the contributing and mediating factors in this, to establish what the organisation could do to assess burnout and what strategies and support needed to be put in place, and to identify if there was any particular clinical discipline more at risk of burnout than others, and to explore what impact longevity of service had on burnout levels. So quite an ambitious project. Didn't feel ambitious at the time, it's just something I thought, oh, this sounds really interesting. But as I got into it, was like, oh, I've maybe taken on quite a bit here. So part of the backyard project was to see what literature there is out there, what research and literature is informing practice and what has been looked at already. So we know as social workers and social care professionals, we're familiar with the term burnout and what it is, but actually it's conceptualized as a psychological syndrome characterized by emotional exhaustion, depersonalization, and reduced sense of personalized accomplishment. Burnout among healthcare professionals has become an increasingly political and urgent concern, especially in emotionally demanding fields like palliative care. And palliative care staff provide holistic support to patients with life-limiting illnesses, often working in highly pressurised environments which require sustained emotional and interpersonal engagement, and over time this can lead to burnout. However, some of the research would say that although working in a stressful environment does not necessarily lead to psychological distress, the levels of stress, depression, and anxiety associated with palliative healthcare provision is high. And there's been lots of research within palliative care exploring the psychological well-being for issues for patients and families, but in comparison, very little addressing the psychological well-being of palliative care staff. So a number of the research articles and the literature would say that staff support is a vital issue in palliative care, citing that employers have more than a legal responsibility to ensure staff well-being, particularly as it impacts directly on the quality of patient care. And now that we're moving to, there's more movement towards looking at civility saves lives initiatives and human factors and looking at all of that. It is, it's something that's very, very much talked about at the moment, is how we need to look after our staff. So the studies that have been done have documented high burnout prevalence in palliative care staff, with emotional exhaustion rates being reported in 30 to 60% of cases. And risk factors include work overload, role ambiguity, lack of institutional support, and compassion fatigue. But what I would say is that that's probably not unique to palliative care staff, that many of us who are working in health and social care and third sector organisations would also say that there is a lot of work overload. We don't have enough people to meet the needs and the demands of the service. One cross-sectional study suggested that 25% of palliative care nurses had high burnout levels, but it does range quite dramatically within the different services. One of the things that we looked that was prevalent within the research was that much of it focuses on on medical and nursing colleagues, with very limited attention on other members of the MDT that work within palliative care. And that narrow focus may overlook the variation in how different roles may experience burnout. Okay, so the research method, I created a staff survey which was circulated to the MDT members and had hard copies in staff room. So anyone who's not familiar with the NI Hospice layout, we have an inpatient ward of 18 single bedrooms. Our care staff, so our nurses and healthcare assistants, wouldn't necessarily have daily access to a computer. So that's why I left hard copies in the staff room. I gave a 3-week window to complete with one reminder from team leaders. So I did not necessarily send out the reminder. It was the team lead. I contacted the team leaders for each of the team. So the inclusion criteria was that it was MDT staff employed in the hospice IPU. So I had to be very narrow about that. I was interested in capturing what was happening in the inpatient unit. So for that point, we had to exclude community-based staff, bank, and agency staff, that we wanted this to be their routine day-to-day job. In terms of ethical considerations, it was really important that the individual consented to participating, that they didn't feel compelled or forced into it. So it was a voluntary participation. And as a manager, I had to be very careful that I wasn't putting too much onus on my own staff to fill this in. Confidentiality was really important. We're asking about a tricky and difficult subject around how they're feeling and what support we need. So confidentiality was important. And so it was an anonymous feedback. I came up with a distress protocol, making use of the organisational supports that are in place to help minimise the risk of harm to myself or to participants. So there are a number of tools that we can use to collect information on burnout and burnout risk, burnout needs, and burnout levels. I wasn't particularly familiar with any of them, but which has been quite useful then to have as part of the research project. So due to cost constrictions and length of surveys, I decided to use the burnout assessment tool, which comes as a standard version or as a short version, which was much more condensed, which is what I used to make it more accessible and to give us a snapshot. So it measured exhaustion, mental distance, cognitive impairment, and emotional impairment. But I also wanted to include what their professional role was, the time and role, the aspect causing most stress about working for the hospice, support services offered by hospice services which they used, what they did inside and outside of work, and what was most useful, and what could we do more of. So I had aimed to survey about 60 people. I thought that would be a good representation of the number of people that it was sent to 60 people. But 22 responded, which was a 37% response rate. So it's a workable number, but it does mean that it's a limited survey result because it's not representative of the entire staff team in the IPU, as there were no responses at all from our healthcare assistants and only one response from our physio and our AHPs. There's only one physio and no occupational therapists. So, but you can see there are nurses, medics, social work, admin, chaplain, and physio. And I looked here at time in role as well. So you can see that most people were within the 1 to 5 year, then followed by more than 10 years, 6 to 10, and then less than 1. So interestingly, those in post for 1 to 5 years recorded a marginally higher burnout risk with an average score of 2.58, which elevated them above other groups, which was followed closely by those in post for 6 to 10 years. So the green here represents that there was no risk of burnout, and you'd be very pleased to hear that 55% of the hospice staff fell into this category. That was 12 people. The orange then is low risk, and that's 27%. And then there was 4 people who fell into the at-risk category, which was 18%. But overall, the mean average of the burnout scores was 2.36, so the maximum was 5. And you can see that overall, the hospice staff fell into the green, which is no risk, which is really positive and not what I expected to find. I expected that our burnout rate would be higher. I've already spoken about this, that those in post for 1 to 5 years recorded a marginally higher burnout risk with an average score of 2.58, which if you look back is into the orange section. So research indicates, why is that happening? What is it about length of time in hospice and in palliative care that makes you more at risk? So research indicates that those who have been in post for less than 5 years are often less clinically experienced and have higher levels of emotional exhaustion due to limited exposure to end-of-life care and a steeper learning curve in managing grief and loss. So some studies report higher levels of compassion fatigue in your staff, linking this to lower skills levels in coping with trauma. So if you're in for less than a year, you're still getting used to it. You have that support, you're still being mentored. But after that, then you've hit the ground running, and that's where we do most of our learning. But given the negligible difference in levels of burnout across the staff team and the different ranges of time and role, I feel, length of time in service does appear to have an impact on practice and on burnout. But it's more important to consider time and role alongside other factors such as workload, coping skills, support, and personal resilience. So it's not time that is important, but what has happened during those years. So time in service provides an opportunity to learn from previous experiences, and these learning opportunities provide the opportunity for growth and cultivation of personal coping strategies. Now, again, I am not surprised by this result, but the profession with the highest risk of burnout was among the social work team. So that was both the highest scoring individual and the highest scoring team. And you can see there the other professions. So, but why social work? Why is social work reporting the highest level of burnout? So there's a range of theories that both me and proper academics and researchers can come up with. But social workers in palliative care face higher burnout, potentially due to the intense chronic exposure to death, which we aren't trained for. When I came into the hospice, I didn't think I would necessarily be seeing people who had passed. It sounds really silly when I say it out loud, but that exposure to death actually was quite surprising to me, the number of people that you would see after they have passed. And the emotional labor that comes around supporting not only a patient in their last days, weeks, and months, but also family members and helping them journey alongside the patient. There's high workload, it is pressurized at times and fast-paced. It's a medical environment. We are social workers very much within a medical model and trying to marry those two up. And that there's very complex ethical issues to consider, and family complexity is growing as our patient demographic changes. And sometimes this can lead then to exhaustion, compassion fatigue, and lack of, which is sometimes compounded by a lack of institutional support. We as social care practitioners, our work is often therapeutic and we contain the emotions and distress of other people. And what I find as part of this exercise is that the social workers tend to lead the debrief and the personal conversations and things for other staff members, which adds to our load. Causes of stress when I surveyed the staff team was far and away workload was the biggest issue reported by people, but very closely followed by workplace conflict. And then sort of work-life balance issues. People weren't getting away on time. It was difficult trying to fit in shifts around family commitments, that people weren't necessarily getting access to the flexible work time that they needed. We're very lucky that the hospice offers a lot of opportunity for support and to reflect on the type of the work that we do. And you can see that it is actually quite well attended and quite well used. Probably the more in-house things are used much more regularly than the formal structure of an employee assistance programme that offer counselling. And people find it useful, that the debrief and reflection and supervision and MDM structures were really useful. Okay, we also know that people do things in work that aren't formally offered, but that we make friends. We have particular peers that we would talk to. Our tea breaks are really important. We always try and make a point of having 3 o'clock tea on the ward and only if time constraints allow, but it gives us a chance just to touch it base and check in with each other's. Outings organised by work colleagues, so things like hen parties and things like that were always popular and a good way to sort of catch up and to take time out of work and things like that. So self-care techniques that we're encouraging people to do outside of work. People really prioritise spending time with family and friends, which isn't surprising given the nature of the work that we do. What more could hospice do? So apologies again, that's got cut off a little bit. But one thing that interested me was one staff suggested that we should appoint a social worker for staff support so that we know who to run to when we are struggling. So it's good that the whole staff team see the social workers as supportive, but knowing that they're the ones that have a higher burnout risk, it's interesting to know what to do with that. So I've gone through this, so we'll not. I know we've got lots of people to talk today. But what our main conclusions were that staff appeared to participate in a range of beneficial formal supports offered within the hospice, and it appears that the organisation is meeting the needs of its workforce by providing a broad range of supports, which is so important. And this project highlighted that many staff are engaged in other activities to maintain a healthy work-life balance, including talking to colleagues about impactful or challenging days, and leisure activities such as being in nature and other self-care activities that they do. So the recommendations are that we should keep doing what we're doing. We need to offer a broad range of opportunities to debrief and to tackle our burnout because we are different people and we need to offer a wide range of things so that they're suitable for most people. We need to encourage work-life balance and activities, promote balance between formal and informal activities, and support those who perhaps have a higher susceptibility or risk of burnout. So when we say explore issues around the workload, we need to make sure that we're not giving the same person, like say for example, the same social worker, all the young patients that come in. We're not all the same patients that have challenging home environments to try and discharge to, that they're mixed up and that people have the opportunity to sort of tap out. Similarly, when there's patients with a high nursing burden or challenging behaviours, that's floated and around the team. So that is my presentation. I probably have gone over time there. Sorry, Audrey and Alison. Let me stop sharing. So whistle stop tour, that took forever. And Audrey did keep telling me, you might want to think about narrowing it. And I was like, nope, I can do it. I am going to do it. I barely did it, but it was very interesting. And I think it really surprised me to know that we weren't burnt out, because being on the ward felt like we were a staff team who were struggling. But actually, when we looked into it, it was we're fine. We are coping fine. And that actually probably that venting was a good self-care technique as well. So that was really reassuring. And the organisation has taken a lot of heart from that as well. We are doing things, but we need to continue doing it as our work continues to grow and as our complexities continue to grow as well. And that we shouldn't think we've got it right. There's always things that we need to do and things that we can change and add in to make sure that we're meeting everybody's needs.
Lovely, Aislinn. Thank you very much. It was very, very clear and very interesting, and also to see that you're addressing some gaps in the research as well. So hopefully you will get that published at some point in the future and add to that. I don't see any questions in the chat, but I was just wondering, Aislinn, if you have reflected on, I know you said it was 22 out of 60 was your response rate, which was 37. Is there anything you think you could have done differently to increase the response rate or to engage the healthcare assistants?
Yeah, so since we have, since that backyard project has been completed, we now have like a grassroots group that has been set up within the ward. So perhaps using them as an opportunity to promote the survey would be a good way forward. And also, periodically each separate team will have a full meeting. People will be requested to come in, so making use of those team meetings and things. The unfortunate, I suppose, how the teams are structured does make those opportunities more limited, because our healthcare assistants wouldn't necessarily come to MDMs or to handovers in the morning. But maybe coming in early on a morning to do handover, or to talk to the healthcare assistants while they're waiting for their day works to begin would be a useful strategy. Making
Yeah,
yourself available to them rather than trying to catch them on the hop. Yeah.
yeah. I know. And it was interesting just what you'd said there about you had focused. I know I was trying to keep you reined in. You focused on the inpatient unit because that's where you wanted to. But do you think that staff working in the community might have had similar um levels of burnout as well? Because I'm conscious
Yeah.
that a lot of them work on their own more than the inpatient.
Yeah, absolutely. And I think, there's a lot of our nurse, so we are staffed by nurses in the community. We don't have any social workers in the community at the moment, but I think that so there's nurses and healthcare assistants, and it's the lone working piece that they feel solely responsible for that individual. I'm lucky if I feel that one of my patients isn't as well, I can ask a doctor or a nurse, can you just check in on them? But actually, they're sometimes leaving a house knowing that nothing has changed. So it would be really interesting to survey them and to see, what their stress levels are like and what are the things that we can do to support them. Because they don't have the opportunity for the debrief or anything like that. They very much are reliant on having a good team support around them.
Yeah, and I've one final question for you. That you'll maybe come back and do your masters with us, Aislinn, and do that project. But
Do you think you should go with me, Audrey?
you mentioned some of the workload, the workplace conflict, and that work-life balance were the sort of top three stressors for people. How did senior management respond to that?
Well, I guess, there was a this is the type of work that we do, but there was a very concerted effort to make sure then that staff were rotated round. So I think a lot of the workload was we sometimes would have patients in that have a very high nursing burden. So perhaps there would be assistance of 4 people to move, or they would have very complex dressings that need to be done, and the time being spent with those particular patients was a lot. So there was a very concerted effort then to move staff around and to rotate, to put an extra staff member in as and when that was required. So we also then looked at our volunteering structure. So peak times around meal service and things can be very challenging because the healthcare assistants are expected to do dinner service and manage the patient's personal care, but actually the volunteers can help and want to help with dinner service. So it's how we can best make use of the resources. So they're very supportive, and I would hate for anybody to think that they weren't. They're very open to ideas, but obviously, like most organizations, we're bound by the resources that we have and how much we can additionally invest. But no, they're very open to suggestions. Yeah.
That's great. Sorry, I see Kathy Payne has just put a question in there. So wondering about the workplace conflict was next highest after workload. Can you speak a wee bit more about that, please? And then we need to move on.
Yeah, so it was a very well-known workplace conflict in a particular team, which was being addressed, but was having then a fallout amongst the full MDT that it's like playground stuff, people were taking sides, and but it was being dealt with through HR and sort of the organizational structures, but the impact was still felt by the MDT. So thankfully the organisation were really sorting that, but it was just interesting to see it coming up as an issue.
Yeah, that's interesting. I suppose it was just about the timing of your survey as well.
Yeah.
Well, Aisling, thank you very much. That's you out of the hot seat now, and I'm going to put Mags in the hot seat. So Mags is from Northern Trust, works in Antrim Hospital, and she was exploring advanced care planning and those sensitive conversations in the acute hospital setting. So over to you, Mags.
Thank you so much, Audrey. Let me just share my PowerPoint here. Okay. Can you all see that?
Just a wee bit on a go slow, Mags, but it's coming. Just needs to go into presentation mode.
Wonderful. Okay. So yes, my project, entitled Meaningful Conversations, so exploring interdisciplinary team knowledge, awareness and understanding of advanced care planning in an acute hospital setting. So mine was really insights from a small scale backyard staff survey. So firstly, thank you to NHSCT for the opportunity to present my research project. Just formally would like to thank the Northern Health and Social Care Trust, to my managers, social work and MDT colleagues. The course was 2 years, so I really appreciate the fact that I was given permission to go ahead with that. And social work and MDT colleagues for taking part in the survey.
Aisling, or Mags,
oh yes,
can I interrupt you 1 wee minute?
Yes,
my slide isn't moving. I'm not sure about others.
Oh right, it's a thank you.
It's still on the first slide.
Oh, is it? Oh,
you're still on the first one. You're not in presenter mode.
Oh no, let's
or from beginning. There, that should move now. Let's see. Yeah, so just a wee bit slow on the go.
Has it changed now?
That's your thank you slide. Yes, that's
thank you perfectly. So I say thank you to Audrey, Deirdre and Irene for their steadfast support throughout the 2 years. Really couldn't have done it without them. So I have been a social worker for 26 years, and unbelievably 18 of that has been within Antrim Area Hospital social work team. It's a generalist social work role, and I have the privilege to meet with many individuals and their loved ones who may be living with life-limiting illnesses and thus in receipt of palliative or end-of-life care. and who are in need of social work support. And for myself, I don't say it's not a specialist role. So it can be within sort of various ward settings, and that can include respiratory, renal, stroke, surgical, or general medicine. So lots of experience around different areas in the hospital. So one of my primary aims is to provide holistic assessment of need supported by my MDT. Invariably, working within the hospital, the focus is on supporting discharge. And as part of this assessment, I may become aware of an advanced care plan on an individual's electronic record, or I may have, based on an individual's consent, conversations regarding care preferences or future wishes, thus encompassing advanced care planning discussions. So really my motivation for doing the postgraduate diploma was to further my development. I really wanted to do better, to be better informed and more knowledgeable, and provide the best social work service that I could. The course did that and more, thoroughly enriching and inspiring, and that is both personally and professionally. And I loved the learning and the friendships that were formed along the way. So the final assignment, the research piece, which I'll present today, was certainly daunting. I have used research, but I didn't think that I would ever conduct any. However, with Audrey's steady guidance, it all became very clear, and actually became quite emotional towards the end. And that wasn't because I had 5,000 words to write. Once it became sort of all began to knit together and to make sense, it really started to mean something. So it was, I say, it was a really great experience. So just a final note, obviously this is quite a emotive subject, so please look after yourselves as you listen. Turn the camera off if you want. Okay, has that moved on for you?
Yes, Mark.
Yes, great. Okay, so I'm sure you are all aware, but I thought it might be useful just to provide that definition of advanced care planning. So this is an international consensus definition. So really to enable individuals to define their goals and preferences for future care and treatment, and that those goals are discussed with their family and healthcare providers. Okay, so advanced care planning, certainly in Northern Ireland, is an umbrella term covering personal, legal, clinical and financial planning. It's really to ensure that any future social care is congruent with a person's previously held wishes and values and beliefs. And this is of particular importance should somebody lose decision-making capacity. Certainly within, say, Northern Ireland, the main sort of driver, sort of policy driver would be advanced care planning for now and for the future, which encourages all adults, regardless of age or health status, to reflect on and document their future care preferences. But the reality is that it's most often introduced to individuals receiving palliative or end-of-life care. It's an entirely voluntary process, and it is an individual's choice, entirely their choice. And as such, it promotes a human rights and person-centered approach to palliative care, so strongly aligning with social work, ethical principles and values of empowerment, self-determination and choice. So the aims, really, therefore, I really wanted to test the understanding and knowledge of advanced care planning within my members of the interdisciplinary team within the hospital. So really framed within the ambitions of for now and for the future, which aims to normalise advanced care planning conversations. Certainly research had showed that hospitalisation could act as the necessary prompt to offer advanced care plans. And within the context of Northern Ireland, in the policy, it's stated that this can be completed by any health and social care professional involved in that individual's care. So as I say, I really wanted to test out that theory. So born out of the policy procedures within work, my curiosity and really area of special interest, that's what led to the project, looking at the knowledge, awareness and understanding of advanced care planning within hospital. So first of all, it was prudent to begin a sort of literature review of the topic. So that was my first starting point. So I completed a review of peer reviewed research articles, which involved a search of 5 electronic databases, and clear search terms were used. So the type of words that I used were advanced care planning, hospital, inpatient, multidisciplinary, social work, awareness, knowledge, and confidence. So I had over 36,000 hits. So I really had to get that right down. So once I went through that, 9 studies were selected for inclusion. 2 were UK based, and the remaining were sort of international perspectives. So I applied a qualitative content analysis to the literature that I had selected. So there was 2 main themes coming out of that literature review. So the first one was that really recognition from staff that advanced care planning is, that they recognise the value and the benefits of it. Things like it was seen as a key indicator and contributor to high quality person-centred care, ensuring that assessments and interventions are aligned with that person's individual wishes and preferences. The literature also showed me that it was associated with improved satisfaction for staff, for that individual and for their loved ones. And also reduced, having an advanced care plan reduced any sort of decisional crisis towards the end of life, again, for individuals, their families and staff. So preventing any unwanted medical interventions or unnecessary moves. However, despite the positives that were shown from advanced care planning, there were barriers noted by the MDT. Issues around a lack of training, knowledge or understanding, lack of time within a busy healthcare and hospital environments were emphasised, and really ambiguity regarding who should have such conversations, with many not viewing it as part of their job role. Therefore, although the study selected sort of suggested that advanced care planning is sort of widely recognised as beneficial, it is largely underutilised. As I found in one of the studies, only 4.8%, in a UK study, only 4.8% of patients had evidence of an advanced care plan. So based on my literature review, there was a notable gap in literature regarding the social work experience of advanced care planning. So it was mostly medical and nursing focus, and also a gap on the sort of Irish context. Okay, so the methods that I used to gather the information for this project was an online staff survey, and Microsoft Forms was used, and it really did allow for sort of instant results. So the survey consisted of 15 questions, and it was a mix of Likert scales, descriptive rating scales, closed questions, yes or no, and open questions. So for example, I would have asked, on a scale of 1 to 5, can you rate how confident you feel having advanced care planning discussions? Open-ended questions provided more depth. For example, can you suggest any ways to enhance your understanding of advanced care planning? So the staff survey was circulated to interdisciplinary team leads to disseminate at random to their team members, and that was really to reduce any selection bias. It included hospital social work, occupational therapy, nursing and medical staff. I'd given them 2 weeks to complete. However, the majority of the responses came back within about 3 days, and I was able to see the responses instantly because of the Microsoft Forms. And on average, the survey took about 5 minutes to complete, 7 minutes to complete, sorry. Okay, so sort of the ethical considerations for the survey, similar to Aislinn's, prior permission was granted from all the team leads. The rationale for the survey was explained, and there was full transparency throughout, and that was repeated throughout with all email communication. It's entirely voluntary. And given that it took 7 minutes to complete, it was quick and available online to staff. I really didn't want to burden them when they were already busy. And I say their privacy and confidentiality was ensured throughout. Okay, so although I can't share all the responses, I just want to give you a flavour of the information that I'd collected. So similar to Aislinn's, the overall response rate was lower than I'd hoped. So say 110 invites with 35 responses. So it may be reflective of a busy hospital environment, maybe limited time available, maybe concern about gaps in knowledge, or maybe people not identifying with the topic. Similarly, the majority of replies were experienced staff, with over 74% having been qualified for 10 years. Okay, so this is a collection, sort of representation then of one of the questions: how would you rate your general understanding of advanced care planning? So encouragingly, 82.9% agreed that they were fully aware or aware of advanced care planning. So there was a good baseline of familiarity within staff. This looked at advanced care planning as part of the job role. The perception of advanced care planning as a responsibility varied, as you can see, with over 62% strongly agreeing or agreeing that it was part of their job role. Notably, 28% remained unsure and 8.6% disagreed. So among respondents who identified advanced care planning as part of their job role, confidence in having discussions was measured using a Likert scale. So the mean score of 2.97, so it reflected a moderate level of confidence in having such discussions. I asked a question regarding training. Surprisingly, 71% had stated they had never completed any advanced care planning. That was really despite many resources being available within the workplace and outside of the workplace, both online and in person. So despite the opportunities, the low numbers suggest, again, it's either a time issue or they don't identify with it as part of their job role. So indicating maybe a different approach might have to be taken. So overall, I say there was a general understanding, say that the results showed me there was a general understanding of advanced care planning, but notable gaps emerged from the survey regarding policy awareness, low numbers regarding training, and reduced confidence to have advanced care planning conversations. So I'm going to move on now to the qualitative open text questions. And this is what really tugged at the heartstrings when I started to read them. So inspired by Braun and Clark, I applied a thematic analysis to really search for meanings and patterns to the responses. So the theme one that I identified was that advanced care planning should be used as an opportunity to encourage people to think about their future care wishes. So you can see some of the responses there: to allow patients to accept or decline any interventions offered, and that care is likely to be more fluent, timely, and to be in line with their wishes. Helping patients proactively consider how they would wish to be cared for in the event of various scenarios. Theme 2 then was really around training and education, with individuals suggesting maybe workshop type training depending on their job role. Reflecting on that it's sort of there's a medical or nursing focus. They're saying really all professionals have a responsibility to be aware. And finally, just the need to push forward with breaking down how simple it actually is. Any short statement of what somebody wants is a form of advanced care planning. So really, the responses across the qualitative and quantitative survey responses would have mirrored what I had seen in the literature review that I'd done. Staff generally recognise the value and importance of advanced care planning. It's an important part of person-centred care, but there is a mix of knowledge and understanding of advanced care planning, and it's often not viewed as part of a job role. So really, it was suggested there was disparity between the positive staff attitudes and the actuality of advanced care planning being implemented in practice. So really, I felt the majority of staff would benefit from further education regarding advanced care planning, with the suggestion of small workshops or in-person training applicable to their job role. So as I say, specific advanced care plan and training, dependent on their job role, would be beneficial in the form of workshops or small group settings to make it relatable to everyday practice. But the reality is, for social workers, this is what we really do already. And I think a lot of it is that we're just not naming it as such. And I think it's important to reflect today, those conversations that we have quite regularly, when recorded, documented, can form part of an advanced care plan. From the individual whose wish it is to be at home with loved ones, to someone who would feel more reassured being cared for in a nursing home environment. All these preferences for care can form part of an advanced care plan. So I have presented my findings to hospital social work colleagues, and I've held a recent journal club on advanced care planning. It's my ambition that the findings of this small project can be further developed to assist in wider social work education throughout hospital and community teams. So I just want to leave this with you. A 5-minute conversation and a document can really make all the difference. So if I cannot do great things, I can do small things in a great way. Thank you.
Just trying to see if Audrey's still with us. She's on mute at the moment. And in her absence, I will ask, has anyone any questions for Mags? I don't think there was any on the chat. No. Everybody is silent.
All right.
And there's Audrey back. Audrey might be able to have a few questions.
Problems with me there. Thank you very much, Mags. That was fantastic. I see Siobhan has put a comment in the training there saying all staff now have mandatory training, level 1, 2, and 3. Do you think this will make a difference?
Absolutely, and I'm glad to see that. It's really just getting staff to identify that it is part of mandatory training, and certainly it's something I'll be promoting within the workplace. It's very much I really want to champion this. All staff have a responsibility, and I say even the occupational therapists, when they're doing their assessments, these conversations can come up naturally. It doesn't have to be a formal thing. So I really just want to get that awareness out there.
Yeah. I know, I think you're absolutely right, Max. And there's something about breaking it down, and actually people are maybe frightened of the big title and the policy, as opposed to recognising a lot of what they do in practice. Sorry, Kathy has asked, is this something where not many or any people are admitted with an advanced care plan, therefore it's not on staff's radar?
Certainly, I mean that's what I meant to ask, and I meant to reflect in the slide. When I think of my own practice, I can count on one hand throughout 26 years, the amount of advanced care planning that I have seen, and I wonder if that's everybody else's experience.
Yeah.
But yes, it's not something I would see very often.
Okay, thanks very much, Mags.
Okay, there's two hands up.
Oh, right,
Gillian
sorry.
and Siobhan's.
Comments in the chat. Sorry, Siobhan, did you want to ask a question?
And Gillian.
Sorry, Audrey, it's Emily. It's not sure.
Okay, yeah.
Jumping on here, no laptop today. No, it was just to say I was at the well done, Maxwell. That was, and both presentations absolutely excellent, and I am just sucking it all in for selfish reasons as well, because I know what's ahead. It was just to say I was at one of the workshops for the advanced care planning for rolling out the training in Villa, and I suppose from a social work perspective, if it is very clinically led at the minute, with even with the new respect stuff, and social workers weren't, I suppose, even on the radar for the level 3 training, whereas I kind of chatted to I can't even think of her name now. Primacy, the clinical engagement group. I think social workers really need to fly their flag here, because we are having these conversations all the time. And I think in the new respect, because DNA, CPR, it's all kind of amalgamating, while we won't ever sign off on the DNA stuff, I think we really have to shout loud and hard that we are having these conversations all the time and are very well placed to do a lot of that respect document. So it's just to kind of encourage people to continue to do that.
Yeah,
absolutely, Siobhan. That's great. That's great to hear. And certainly from this project, I plan to put in a quality improvement in September. I'll be putting in for that to try and move this forward within the trust for social workers. So.
I'm sorry, I'm very conscious of time here. So if anybody else has any questions for Mags, you can put them in the chat, and hopefully she can come back to you. I want to introduce Natasha. I'm conscious we've 2 more to present before we finish. So Natasha, do you want to go ahead? Or sorry, it's not Natasha, it's Eibhlin. Sorry, Eibhlin. I wondered why you were looking at me there, Natasha. So Eibhlin, go ahead there.
In fact, I'll just share. Give me 2 seconds. Is that sharing okay?
Yes.
Perfect. Okay, so my name is Eibhlin, and I work as the Bereavement Care Coordinator and Specialist Palliative Care Social Worker at St Vincent's University Hospital in Dublin. And today I want to talk about my research, which explores the question, how effective are structured bereavement information events in compassionate communities? This research comes directly from my own practice and a gap that I've observed. Many bereaved people want support, but don't always know where to find it or whether the supports that are out there will meet their needs. Bereavement affects a significant proportion of the population. In Ireland, there's tens of thousands of deaths which occur each year, and it's estimated that 4 to 10 people are impacted by each death. So I know in my own hospital, last year there was 1,000 deaths, so it would mean that there's about 10,000 bereaved people after those deaths. Despite this, research and service provision show that many bereaved people do not access formal support. Support is often generic rather than tailored, and access can be inconsistent or dependent on location, awareness, or confidence to ask for support. In my own workplace, there is an additional challenge. So under the Data Protection Act, I can't contact bereaved families unless consent has been given. And at the time when a death occurs, it's often too distressing for family to fill out a consent form. However, what I have noticed is that months later, bereaved people do actually contact the social work department, and they're usually looking for information, reassurance, and community-based bereavement supports. Before I move on to the research itself, I want to briefly explain the role of the Dublin South Bereavement Network. It is a collaborative network of hospitals, hospices, and community organisations that provide support to people who have been bereaved, and it was established in 2020 and operates using a compassionate community approach. The purpose of the network is to improve awareness, access, and the coordination of bereavement supports across South Dublin. Rather than working in isolation, member organisations work together, share information, resources, and learning. Importantly, the network recognises that bereavement support doesn't sit solely within the healthcare system. It acknowledges the vital role of communities, informal networks, and social connection in supporting people through their grief. As part of this network, structured community-based bereavement information events are organised for the public. The event that informed this research was one such initiative and was designed to provide psychoeducation, emotional validation, and signposting to services of supports that is not in a clinical environment. The research was grounded on three main areas. So bereavement psychoeducation, compassionate communities, and strategic drivers, which included national palliative care policies. Bereavement psychoeducation recognises that grief is not linear, nor does it look the same for everyone. It can affect people emotionally, physically, socially, financially, and spiritually. Research shows that having accurate, compassionate information can help people. It helps them understand what way they are experiencing their grief, reduce self-blame, and feel less isolated in their grief. From a policy perspective, Ireland has made great progress. So the National Adult Palliative Care Policy places bereavement care within public health and a community framework, rather than viewing it solely as clinical. This aligns closely with the concept of compassionate communities, which promote a bottom-up approach, social connection, and shared responsibility for care at end of life and during bereavement. Rather than replacing professional services, compassionate communities complement them by strengthening informal supports and community awareness. The study that was used was mixed method research design, combining of both quantitative and qualitative data. The research was carried out following a 2-hour structured bereavement information event. And you can see on the side there is a poster, and it was called Living with Grief, a Bereavement Information Evening. The event was organised through the Dublin South Bereavement Network, and I was a part of the event team. The event was free and open to all adults that have been affected by bereavement. Attendees could attend either in person or online, and a questionnaire was distributed at the end of the event. So 185 people registered for the event, with 108 people completing the survey at the end of the event. So for the methods, so the questionnaire consisted of 12 questions. These were both closed questions, Likert scale questions, and then open-ended questions as well, so we could get the response. Then for data analysts, for the quantitative data, I used SurveyMonkey and Excel. And for the qualitative, I analysed it through Vaughan and Clark's 6-phase model. So for ethical consideration, I got ethical approval through the Dublin South Bereavement Network, and all participants consented, and their data was anonymous as well. The sample size was non-random and self-selective. So the key findings, now there was a number of findings, but I'm just aware with time constraints that I'm going to only touch on some of them today. So the findings strongly suggest that structured bereavement information events are effective. Firstly was, why do people attend? So over 80% were seeking help for their own grief. Many wanted information about available services, and others attended to better support someone they knew who were going through bereavement. So secondly, around half of the respondents found the event very or extremely useful in helping them cope in their own grief. Similar levels of usefulness were reported for helping others and learning about services. Then thirdly was the emotional connection that emerged. was a dominant theme in the qualitative data. Participants repeatedly spoke about feeling less alone, feeling validated, and realizing their grief was normal. One participant, and you can see in one of the slides there, that they said that I felt like I was not alone. Another described the event as a refresher course on how to deal with the awful pain of grief. This is a sense of shared experience, and normalization was central. Finally, the data showed strong support for future events. Nearly 59% said they were extremely likely to recommend similar events. No participant said they would not recommend them. The findings reinforce that informal and community-based support is often the most accessed and most valued. Emotional connection can just be as important as professional intervention, and psychoeducation helps people make sense of their grief without pathologizing it. An important insight was the risk of overly prescribed or prescriptive grief models. Several responses suggested that rigid, stage-based approaches can make people feel that they are grieving the wrong way. Instead, using models such as the dual process model for bereavement, which allows movement between loss focus and restoration focused coping. And this is often more compassionate and realistic framework as well. An unexpected but significant theme was the financial strain following bereavement, highlighting the intersection between grief inequality and social isolation. Like all research, there were some limitations. So these included that it was a self-selective sample. It had limited geographic data. I was in the role of the researcher, but I was also on the events team. And the study was geographically limited to services linked within Dublin South Bereavement Network. Now, in saying that, anyone could have attended in Ireland online, but it was actually based in Dublin City Centre. Further research could explore themed bereavement events such as spousal loss, sudden death, or longitudinal outcomes, and in-depth qualitative interviews. To conclude, this research demonstrates that structured bereavement information events within compassionate communities are effective. They promote emotional connection, normalize grief, increase awareness of services, and reduce social isolation. Most importantly, they offer bereaved people a space to be seen, heard, and supported without judgment. This study supports the argument that bereavement care works best when healthcare systems and communities work together with compassion as a guiding principle. And so a big thanks when actually doing the study, a big thanks would actually go out to the participants that who attended, but also completed the survey and the Dublin South Bereavement Network. And then we actually get funding through the Irish Hospice Foundation and Flanagan's Funeral Homes. And then to my own manager, who's always been very encouraging, and actually, when I was telling her that I was going to be doing the palliative care postgrad course, she very much was for that and gave me the time to do that as well. And then my own tutor who helped me with the backyard project, Irene Murphy, but then all the lectures at Queen's, I really enjoyed the course. And much like Mags, it actually did have a massive impact both professionally and personally. So I couldn't recommend it anymore. Stop there.
Thank you very much. That was lovely, Eibhlin. It's interesting just what you're saying about it was an online event and you got a really, really high response rate to your surveys, which was interesting. But and also interesting as well about you saying about it alleviated loneliness or social isolation. So do you know how that happened as a result of an online event, or was it just, have you any idea why that was one of the key findings?
No, I think one of probably learning from it is that it was hard to know, or probably when I was actually doing the research of why people online felt a certain way and why people in person, and it was a lot easier for people in person when they completed the survey, they were actually able to come up to us afterwards, you know, and actually provide more information. As I felt with the surveys online, it was quite limited. So I think if I was to, like we're doing an event now, so I will be start looking at the questions again. I'd actually ask more about that. But it would be limited to what we knew, as the people actually on the day who came to the hotel could actually speak with us afterwards.
Yeah. So you're replicating it again then with another cohort?
Yeah, and it's great. You know, it's great actually to have that research, first of all, for our own bereavement program in the hospital, to know, okay, actually going out to the community is the right thing, as opposed to doing the events in-house. As before COVID, I didn't work in this hospital, but another program I was involved in, which they did here in the hospital too, would be that it was very much in-house. So actually going out to the community seems to be working. So it's great actually to have that research to see were we doing the right thing.
Yeah, that's very good. It's very reassuring, Eibhlin. Thank you. Has anybody any questions for Eibhlin before we move on to Natasha? I don't see anything in the chat there. Yes, go ahead. No? Okay. Thank you very much. And Eibhlin's one of the brave souls who moved on to the master's project. So she's just finished data collection on that. So well done. Natasha. So Natasha, you go ahead and put up your slide. So Natasha is the team leader in the social work team with older people, or for older people, I should say, in the Western Health and Social Care Trust. And Natasha was looking at referrals being made to her team and how timely they were for people with palliative care needs.
Good morning, everybody. Well, I suppose it's afternoon now. So my name is Natasha Nicholson. As Audrey said, I'm currently employed as a team leader with an older people's team in the Western Trust. And I suppose this presentation summarises my backyard research project, exploring whether timely responses to palliative care clients, does that actually improve service provision within older people's services within the Western Trust? And I suppose this topic grew from kind of daily practice, wherein I had noticed how palliative care referrals were often received very close to the end of life, or those individuals who were deemed to be actively dying. And this then prompted reflection on what timely really means. So basically, the background of my project and rationale, we know that Northern Ireland has, and I suppose it faces, a rapidly, ageing population. And we know that obviously in future now, and with that ageing population, is going to, I suppose, create a greater palliative demand on services. And we know that 1 in 6 people are now aged 65 and over. And I suppose despite this, there's no underpinning legislation specific to older people's teams. Therefore, daily practice relies on, policy and guidance such as, the Care Management Circular of 2010. And whilst this circular mandates the proportional and prompt responses, especially for palliative care, it doesn't define what timely means in the real world or on the ground practice. So I suppose this uncertainty formed the basis of my research question. And I suppose, like I said earlier, I had often hypothesized that referrals to older people's services were not being made as timely as they could be potentially, and perhaps service provision was not as robust as what it could be. And I also felt kind of just in terms of my own professional curiosity and willingness to build or increase the knowledge base of the social work profession in respect of palliative care. Okay. So basically, the literature that I reviewed, within my study, I suppose it talks about timeliness and barriers and the benefits of early referrals. And obviously, we know that there's limited community, I suppose, from my research as well. There was limited and community and Northern Ireland-based research and evidence. And I suppose, the rationale for doing an audit, I suppose Campbell in 2016 would say that an audit is used to determine the prevalence of an issue. And I suppose I chose this qualitative method to collect my data as I realised this was more accessible within my topic of inquiry. And Davis in 2009 stated that literature reviews provide a useful backdrop for the problem or issue that has led to the need for the study, such as who has been writing about it, who has studied it, and who has indicated the importance of studying the issue. So that's obviously why we looked at literature reviews to see what else was out there, and maybe had someone maybe come across this before and had they written about it. And I suppose I compiled a data extraction tool to aid in reviewing the literature during my researches. And I suppose Delaney et al. In 2002 and their Canadian scoping review on ageing further identified important gaps in understanding the perspectives and experiences of primary care providers in an integrated palliative approach. And I suppose this was particularly helpful to my research question in identifying barriers and gaps to timely referrals. And in their scoping review, they used a defined protocol to establish a search strategy to source relevant studies, which were used as a common analytical framework for organising, extracting and synthesizing information. And I suppose in their study, there was 10 relevant kind of studies that were selected in Europe, 4 in the United States and 3 in Asia. And sample sizes included 459 primary care physicians and 195 nurses across the studies. So again, we know this is obviously in Europe and in Canada. Although Delaney et al. In their scoping review, it focused on older people with dementia. And despite this kind of change in focus, I still found this very relevant to my topic. As Delaney and his counterparts rightly state that on a palliative approach to care, that it aims to meet the needs of older people throughout a chronic disease trajectory. And this is relevant to my area of work within an older people's team, which deals with many chronic, life-limiting and palliative disease trajectories, which includes dementia, something we come up against day in, day out. And again, in their review, in Delaney's review, it evidenced the barriers faced by primary care practitioners, including the lack of resources and heavy workloads, which may potentially impact the overall service provision and how quick or not palliative referrals were made to primary care teams, such as ourselves, elder people's teams. I suppose, interestingly, Delaney et al.'s study suggests that primary care providers must be available to manage patients at home for an effective integrated palliative approach. And then on the other hand, the study recognises a major and ongoing limitation with the Western Trust and indeed worldwide, which is the challenge associated with the shortage of practitioners who are well versed in caring for older adults. This is yet another potential gap which could impact the referral timeliness despite the growing number of older adults in the healthcare systems. I suppose the Delaney study wasn't without its limitations, however, and there remains a lack of clarity around what constitutes an integrated palliative approach throughout disease trajectory and not just in later stages worldwide. And I suppose Delaney only included studies published in English, which possibly missed out on other relevant studies and findings in other languages. And I suppose, again, similar, there was another study that I come across was Kujawska. And in 2019, they concurred with Delaney's study and the need for earlier intervention of palliative care may be associated with improved patient outcomes. And their study was from New South Wales, and it highlighted the approach which has been supported by the Australian National Guidelines. I suppose, and it highlights that approach again, the need for integration of palliative care services. And the aim of their study was, I suppose, their systemic review was, again, the need for early integrative palliative care and improving the outcomes for people with lung cancer. And studies were reviewed which reported on the effectiveness of palliative care interventions provided to adult patients, and they used a data extraction tool, and they identified nearly 500 records, and they also identified a randomized controlled trial within the USA, and there was obviously ones used within Australia and Europe they used to compare and contrast. And the review concluded this was, I suppose, there was mixed benefits for the benefits of early referrals to palliative care. However, there was a lack of conclusive evidence for lung cancer parallels for the findings of benefits of early referrals to palliative care and other cancer populations, for example, GA and non-colorectal cancers. And I suppose what they were saying is that early referrals for the likes of GI and non-colorectal cancers evidence a decrease in depression, improved patient quality of life and ability to cope with their prognosis, especially at week 12, within their control groups, which were 27 of those in total. However, early referrals for those with high symptom burden and poor survival rate did not improve quality of life or psychological symptoms in their study, suggesting that routine referrals to specialist palliative care services soon after diagnosis is not needed if access to support services can be provided. Therefore, they make recommendations for further screening for palliative care patients, which the authors suggest should be continuous and at appropriate intervals. Again, Tchaikovsky's study again highlights the issue of trying to unpack the components of early palliative care and what this means. And the lack of consensus within trials or studies completed around early or timely referrals means that it is often defined in relation to multiple entry points and continue to be varied. So I suppose in summary, existing evidence shows inconsistency. Some studies associate early referrals with better quality of life and less stress, while others find no measurable difference. And common obstacles include limited staff capacity, prognostic uncertainty, and public or professional stigma around palliative care. And notably, there are no comparative studies, as we know, in Northern Ireland or within their community services, reinforcing the need for local exploration going forward. So methodology then, in terms of my audit, this was a small scale retrospective audit reviewing real referrals made to the older people's team over the duration of 1 year. So the sample size was quite small, 14 palliative referrals between April 25 to April 20. Sorry, I should have been April 24 to April 25, which was my error there. And I suppose literature had said that audit can be a valuable assistant to any programme which aims to improve the quality of healthcare and its delivery. And I suppose I know audits aren't without their limits either. As you know, Paskins et al. In 2010 would say that a limited kind of sample scope can impact findings as well. And again, I recognise that mine was a small kind of sample. And I suppose it depended on the referrals being made to my team. And I suppose the likes of pre-existing information, which could potentially be inaccurate, leading to flawed conclusions. I suppose, although we can't identify irregularities all the time, we can't guarantee the absence of all potential issues, including those that are hidden. So each case was anonymised and data was extracted manually using a structured tool aligned with the fair access criteria within the Western Trust. And as again, although modest in size, the data set provided insight into how quickly referrals are processed and for how long clients receive support. Okay. And I suppose the key points that my, study showed was that there was a mean age of individuals who were referred. A lot of them were, the average age of the person was 75 years old, and 79% of those referred were predominantly male. And the majority of most referrals were made in May 2024 and March 2025. And I suppose, again, we know most of the referrals were male compared to that of females. 20% males accounted for 79%, whereas the females accounted for 21% of the sample population. So obviously within our team, all palliative referrals were actioned the same day. Many of the referrals occurred or were made late on the disease trajectory from my study. For instance, one client died within a day of referral being made, leaving little opportunity for meaningful social work intervention. This suggests the issue lies less in social work responsiveness and more in when referrals are initiated by other professionals or individuals themselves. However, my results do concur with my initial thinking, and that there is a short time gap between the date of referral and closure to the older people's team, with an average of 3.5 weeks between date of referral and date of death. There was an average of only 3 contacts between the dates of allocation to a social worker until the date of death. And this suggests that potentially not enough time for interventions to be completed. For example, meaningful care support as per the initial referral. In addition, social work is not always the primary service or need for individuals requiring palliative care. Therefore, the use of community palliative care teams and our district nursing teams or Marie Curie can be an alternative to best meet the needs of an individual with palliative care needs or those requiring end-of-life care. And this is concurrent with providing individuals with the right care in the right place at the right time, which falls within the Western Trust overall ethos in terms of their service provision. And in 2016, this principle has been integrated into strategy and their action plan, Western Trust action plan set out in the health and wellbeing strategy, delivering together, and builds on the strong foundations laid by Transforming Your Care and other programs of change. So finally, really, in conclusion, my audit showed that while timely allocation occurs, overall referral timing may still be too late to maximise its full benefit. So to improve service provision, Northern Ireland needs a clear, regionally agreed definition of timely referral supported by training and resourcing. A broader multidisciplinary study could determine whether earlier social work involvement measurably improves outcomes for palliative clients or individuals. Again, we know barriers continue to exist, which include large workloads, staff shortages, and poor knowledge of palliative care processes and policies. Furthermore, Hugh et al. 2022 identify multiple barriers to timely palliative care, also include a lack of awareness of symptoms or needs, inconsistent referral thresholds, and stigma surrounding palliative care. Limited resources and increasing costs to the healthcare system are also an emerging theme. And also causes issues with access to palliative care, especially those with increasing age and non-cancer life-limiting conditions. One of the main themes of the literature reviews also concurs that it remains unclear as to if either referrals for palliative care would make a difference in enhancing service provision. There's also the lack of previous studies completed in community care or primary care settings, whilst hospital and specialist palliative care settings appear to dominate the completed trials or research to date. So going forward, obviously, definitely would need to be thinking about larger scale studies, especially within Northern Ireland. So that concludes the end of my presentation. And again, I'd just like to thank Audrey and the other course tutors for their expertise and support throughout the 2 years.
Thank you, Natasha. That was lovely, very succinct. Really interesting, just as you say, about the conflict between, the literature and your own findings as well, about does it or does it not benefit having that early intervention? Because that's one of the sort of key things that you hear in the policies, isn't it, about early intervention as well?
Definitely.
Yeah.
Definitely.
Has anybody any questions for Natasha? Yeah, I thought it was really interesting. Like you went into a lot of detail about your literature review, and it was interesting just as well to see about the, how you could find studies that were looking at a similar issue but with a different service user group, and I think that's something we need to think about when we're doing literature searches, isn't it? Not refining our search too quickly. So yeah, actually can find those really interesting studies as well. I'm conscious it's 1:30. And we've finished our 4 presentations miraculously within the time. So,
Thank you very much.
Thank you, Alison.
Not at all. And I'd just like to say thank you really to everybody for attending today, and especially to yourselves for your presentations and really sharing your research and your insights. It has been a really valuable session, and it is great to hear about your projects and your findings and your next steps, what you've got ahead of you.